So we've been doing this for the this is our 3rd year, and it's been very exciting if you ask me. Today we have 2 very experienced pediatricians who are going to talk about tidbits in pediatrics, which means very little things in pediatrics that you would want to know, and also how to prevent home accidents. We have 2 pediatricians, Dr. Joanne Wood and Dr. Samira Yamyolia. So Dr. Wood is a senior specialist pediatrician who works at the Bank Hospital. And Dr. Samira is also a pediatrician who works at Ridge Hospital. Both of these wonderful pediatricians also help us at Mission Pediatrics over the weekends. So, Dr. Wood and Dr. Samira, who is starting first? Is it Dr. Hello?
Dr. Wood is starting first.
Yes, okay. So, Dr. Wood, I shall hand over the mic to you, your audience. We are about 29 now. I'm sure some people will join very soon. So you can start with preventing home accidents. Is Dr. Wood on the call now? I can't find her. She may have dropped off. Samira, Dr. Wood has dropped off. Do you want to start whilst we try and get her? Hello? Dr. Samira, are you there?
Dr. Marble, I'm here. So Dr. Wood is joining right now. So she's joining in right now.
All right. Okay. Please give us a few minutes as Dr. Wood joins, and then we can start. Godfred. Godfred,
Hello.
are you there?
Yes,
Dr.
I'm here.
Wood has not been made co-host. She dropped off and came on, so she can't share her screen.
Please, she is now.
Okay. So, Dr. Wood, we are ready. You can start anytime. Please bear with us for the technical hitches.
Good evening, everybody.
Good evening.
Okay, so please, can you see my slides?
Yes, we can.
All right, is it moving?
Yes, it's moving.
Okay, all right. Okay, so thank you very much, Mission Pediatrics, for this opportunity. It's been a pleasure always joining in on Parents Roundtable and also having the opportunity to also share a few thoughts to help one another, even as parents and as caregivers. So this evening, I'll go straight to the point. This evening, we are talking about preventing home accidents. And whether we like it or not, as parents and as caregivers, we are constantly looking out for the younger ones. And unconsciously, we are actually protecting them from accidents and injuries. So this evening, I hope that by the time we finish this presentation, we'll add on to the knowledge that we already have, and maybe we may pick one or two tidbits here and there to help us, even as we look after the children every day. And so this will be the outline of my presentation. We'll go through an introduction, a bit of a background, and then we'll delve into a few specific types of accidents that we have, then we'll conclude. So by way of introduction, I want to state here that every child has a right to a safe environment and to protection from injury and violence. And so, as I said, as adults, this is our duty to make sure that every child is safe and every child is protected from injury and violence. And so accidents, as we know, are a major cause of injury and even death in children. But when we talk about accidents, people readily think about road accidents, accidents involving cars, bicycles, and the rest of them. But we hardly think about the home, which is considered the safest place for all of us, for all children. Yet in this very home where we consider very safe, here are so many hazards that actually affect our children and cause them to be injured or sometimes even end them in death. So according to the World Health Organization, every year about more than 800,000 children will die from home accidents worldwide. And this translates to about 2,000 deaths in a day. And this is very serious. So if you think about it, as we sit here in the next like 24 hours, about 2,000 children are going to die as a result of home accidents. That's very scary. And apart from the deaths that occur from home accidents, many more, millions of children are hospitalized each year for injuries that result from home accidents that are non-fatal. So when we talk about an accident, an accident is an undesirable or an unfortunate happening that occurs unintentionally. So that makes it an accident. It occurs unintentionally and may result in harm, in injury, damage, or loss. We are talking about children here. So who is a child? According to the United Nations Convention on the Rights of the Child, a child is any person who is aged 18 years and below. And they have further classified this group into the 0 to 4 year age group, the 5 to 14, and then the 15 and above age group. And for the purpose of this discussion, we'll be focusing mainly on the 0 to 4 year age group. Okay, so why are these children prone to injuries or accidents? So young children, by their very nature, consider your 0 to 4 year old, by their very nature are very curious. They want to explore their environment. They want to experiment, but then they also do not have the capacity to understand that what they are exploring or what is facing them or staring them in the face is dangerous. And so they are not able to respond appropriately. And so this means that young children will need constant supervision, but this may be very difficult. I mean, in these times where everybody is working, people have multiple roles to play, it may be so difficult to keep an eye on a child constantly. And so more often than not, children are left in the care of people who are not very capable in handling them or capable of looking after them. And then, you know, things just happen, the accidents happen. So I want us to remember that children are not just small adults. They do not have the mental capacity that adults have. Yes, they are developing their physical abilities, but then they may lack the cognitive abilities that go together with the physical abilities. Now, again, children are, yes, they are growing, they are developing. Consider the newborn baby who just lies there, fed, sleeps, and then that's it. But then as they grow older, they begin to roll over, they begin to sit up, they will crawl, they'll start walking. And once they start crawling, walking, you know, they are able to stretch out their hands, they're able to grab things or grasp things, put things in their mouth. And these developmental milestones that are very normal with children, or which we expect with children, are the very things that will lead them to start, you know, putting themselves into danger and getting into accidents and injuries or even loss of life. And again, by gender, it is also said that boys tend to become more injured or more severely injured as compared to girls. And this is because, I mean, boys engage in more risk-taking than girls. They are more impulsive. They like to explore. They are almost everywhere. And again, it has to do with society and how we have socialized boys differently from girls. So many parents will allow their boys to, you know, play harder, kick harder, go to places where they will not allow their girls to go. And with these come the attendant risk for getting into accidents and then being injured or losing their lives. So what are the other physical characteristics of children that makes them more prone to injuries? So we are looking at the skin of children. Younger children have very thin skins as compared to older children or even adults. So let's even consider our palms. The palms of a younger child is very thin as compared to the palms of an older child. And so if these two people were to sustain burn injuries, for example, you can just imagine who will suffer the more compared to the other one. The younger child who has a thinner skin is more prone to more severe injury as compared to the adults. And again, they have a smaller airway. So comparing adults or older children to younger children, the airways of smaller children are smaller. And so that puts them in a dangerous position with the risk of aspirating very little things or very tiny objects. We've already talked about the fact that their physical abilities may not match their cognitive abilities. So there are several types of accidents that cause injury in children, but then they are grouped into 5 main categories. So we have the threats to breathing, we have the falls, we have the poisoning, we have burns and scalds, and then we have drowning. So we'll look at each and every one of these briefly. So the first one we'll talk about is drowning. So we can see in this picture a boy who is in water looking very distressed. This boy is drowning. So we all know how water is very important in our day-to-day activities, in our lives. We need water to do so many things. And for children, the added advantage is that water is actually fun for them. They play in water. They explore in water as well. So even though water is very important for our day-to-day activities as individuals, it can also be a dangerous medium, especially for the very little child who can drown in as little as very little water, few centimeters of water at the bottom of a bucket. And in most countries, it is said that drowning ranks amongst the top 3 causes of death from unintentional injury in children under 5 years of age. So when we talk about drowning, what are we talking about? Drowning is an event in which a child's airway is immersed in a liquid medium, so like water, leading to difficulty in breathing. So water has filled the air spaces in the lungs and the child cannot breathe. And this may result in death or survival. Even when they survive, they may have long-term consequences and disabilities that they may have to live with for the rest of their lives. So what are the risk factors for drowning? Now, children under 5 years of age have the highest drowning mortality rates worldwide. And it occurs most of the time when the child is left alone or with an unqualified caregiver in an area where there's water. So even sometimes when there's a qualified caregiver around, they may not even notice when the little child wanders away and then falls into the nearby water body. So I'm sure we can all remember what happened recently to Davido's son just last year when he was left in the care of so many adults, a nanny, a cook, I think a security man, and all of that. They couldn't find him. The next time they found him, he was drowned in the swimming pool at home. So that is what happens. They wander away, and then before you realize, they have become immersed and submerged in the water. So in general, most children will drown. The drowning usually occurs around the home. And the bathtub in advanced countries is a very common place where children drown in. So you have a child in the bathtub, mommy has left to go and bring something. By the time she comes, child is under the water and has drowned. And again, the residential pools that we've talked about, Davido's case. And then in our setting, in low income settings, people may have dug out holes or pits around construction sites in their home, which may be uncompleted. It may be filled with water, and then the child drops inside and then falls and drowns. So how can we prevent drowning? So eliminating the hazard is the most effective preventive method of drowning. So if you can prevent it, then that is it. You don't even need to think about it. So in the home, what can we do? If we have buckets and bathtubs that are standing around, if you are not using them, don't fill them with water in the first place, because if as little as a few centimeters of water, as we have said, may end up being the end of the child may drown in it, and then that is it. If you have a hole that is dug out in the house, you need to fill it. Once the purpose for which it's been used is done with, just fill it so that the water, it doesn't collect water for the child to drown in. Fencing of pools is another way. And then we've also talked about the personal flotation devices. A lot of the times people have a false sense of security in the fact that, oh, the children have wings and flotation devices in their swimming pools, and so the risk of drowning is zero. But it is never zero. So even though they may have all these wings and flotation devices, we always need to keep an eye on these children in the swimming pool. And again, we cannot overemphasize supervision by the parents or the caregiver. So educating parents and letting them know about the risks of drowning can help, raise the awareness and prevent it. Once we also know how to prevent it, we should be able to also learn we should be able to give the first aid that goes with drowning. So sometimes a child is pulled out of the swimming pool. Yes, they are alive, they are breathing, but they are unconscious. The bystanders who are there, several studies have shown that if you commence CPR, usually the outcomes are good. And so all of us need to learn how to perform simple CPR to save lives. Once a person has drowned, yes, you retrieve the person quickly and then you start the CPR, as I said. So we quickly move to burns. Now, a burn is defined as an injury to the skin or other tissue as caused by heat. So once the heat comes into contact with the skin or the tissue that is involved, then the tissue is destroyed. And some of the heat that commonly are the sources of burns are the hot liquids, the hot solids, and then the flames. Again, children are very curious, they are very awkward, they cannot respond to danger appropriately. And so that puts them at risk for burns. And for the younger ones, the infants, they are now walking around, they are learning how to hold, grasp things. And so it makes it very easy for them to reach out and touch hot objects. And as I said, they cannot respond appropriately. And the skin is also thin, as I said initially. And so that also affects the degree to which they are bent as compared to adults. So the scalds are the most common types of burn injuries in children below the age of 6. And typically what happens is that there's a hot liquid standing on a table or on the stove, and the child just reaches out and holds it, grabs it, and then before you realize, the hot liquid pours onto their hands, the arms, sometimes onto their face. But we also have the contact burns from hot solids, so like a hot iron, and then the electrical burns from faulty connections and all of that. Yes. So where does it really happen most of the time? The majority of burns occur in the home, in the kitchen specifically. So you have mommy cooking, and then the children are also playing around. They may knock things over, or as I said, they are curious and then they hold things. You may also have the outdoor burns where, when people are having fun, barbecuing their meat, and then children around having fun as well. And then they are tempted to go touch the hot barbecue stove and all of that. So what are the human factors that are involved? Leaving children unattended in the bathroom. Again, sometimes we put hot water in the bucket and then we go away and then we come back. By the time you come back, the child has put the hands in the bucket or has knocked the bucket over, and then that has resulted in burn injuries. So the teaching is that you put the cold water in the bucket first before you add the hot water, so that the child does not suffer any injuries. And then the other things, putting hot drinks at the edge of the table, holding a child at the same time as holding a hot drink, children playing in the kitchen whilst the parent is cooking. You have pan handles that are sticking out in front of the stove, and then keeping irons within the reach of children. All these are human factors that we can modulate to prevent children from getting injured from burns. So when burns occur, what do you not have to do? You have to make sure that you yourself, who is rescuing the child who has gotten burns, is in a safe position before you offer that help. You do not apply any paste or oil on the affected surface. You do not apply ice. You do not open the blisters. You do not apply anything directly to the wound. You have to get to the hospital so that the appropriate topical medication is applied. But what can you do? So you can stop the burn process by removing the clothes and then irrigating the wounds with cold water. And then if there are flames, you need to extinguish the flames. So if the child's clothes are burning, for example, they can roll on the floor, or you can use a wet blanket to, extinguish the fire. And then in chemical burns, because sometimes we have chemicals that can actually cause burns, what you need to do is to remove the agent. And if it's gotten into the clothes, remove the clothes and then irrigate the wound copiously with water, and then obtain medical care. We talk about falls. So falls are a normal part of the child's development. Our children are learning to walk. They've sat, they are crawling, they've gotten up, they are walking, they may start running, climbing and jumping. And in doing all of these things, inadvertently, they will fall down. So falls are actually recognized as a normal part of the child's development. And fortunately, most of the falls result in little injuries, if anything at all. But then a few times you may have falls that will result in major injuries, some cuts and then some bruises. Okay, so there's a picture of a child who's falling down the staircase. And what are the factors that are related to falls? So the child's age is important, as we've talked about. The younger the child, the higher the risk. And in fact, sometimes even the older children, with all their boisterous activities, running, climbing, walking, they may fall. And then it also depends on the location of the fall, so the height from which they have fallen. So if you fall from a higher height, it just makes more sense that your injuries will be more severe. But it also depends on the surface on which you have fallen. So if you are falling on a padded surface, for example, your injuries may not be as much or as severe as somebody who has fallen on the raw cement floor or a ceramic floor. So where do most of the falls occur? In the developed countries or in high-income countries or on the high end of society. We have our furniture, our car seats, the prams that we use. Children may fall out of these. And then as children begin to walk, when they fall, they may fall off the staircase, and when they climb the furniture and all that, they may also fall off. And then the older the children get, as they go out and play on the playground, they may be pushed, they may fall off the play equipment and also get injured. And now we have children riding bicycles, the roller skates and all of that. They may fall down and injure themselves. So what are some of the interventions that have been put in place to modify or to make falls less severe? So initially, when the baby walkers and the prams came into being, they realized that their braking systems were at fault. So they've done a lot of modification to that to ensure that the braking systems are good so that the children do not fall down. We have helmets for young riders, elbow guards, shin guards, so that when they fall, they do not injure themselves. And putting safety gates on staircases also helps prevent children from falling down the staircase. And of course, we cannot overemphasize parents' supervision. Now, the almighty poisoning, we'll spend a little bit of time on poisoning because it's one of the commonest causes of childhood injuries. A lot of the injuries that we see in the emergency rooms are as a result of poisoning. And so the home is safe, but then hidden in the home are all these substances that can cause injury to the child. Now, poisoning refers to an injury that results from being exposed to an exogenous substance that then causes cellular injury or death. And we have a lot of poisons that can be inhaled, ingested, injected, and absorbed through the skin. So the severity of poisoning will be determined by the type of poison that the child has taken, the dose, that is the amount that the child has taken, the formulation, whether it is liquid or solid, the route of exposure, whether the child swallowed it or it just came into contact with his skin, the age of the child. The younger the child, the more severe the outcome may be, and the state of nutrition of the child. So a poorly nourished children, I mean, your guess is as good as mine, may suffer more severe injury as compared to a well-nourished child. Okay, so what are the types of poisons? So data collected from many poison centers and hospitals indicates that most of the agents that children get themselves entangled with are the medicines that we use all the time in our homes. So the over-the-counter medications like paracetamol, the cough syrups, the cold remedies, the iron tablets, name them, the day-to-day medications that we have in the house. And then the prescription medications, grandpa's, antidepressants, these are the medications that are always found around in the home. And these are the ones that the children have access to and may take in and end up being poisoned. Apart from that, we have the household products like the bleach, the parazones that we use in our homes, the pesticides, so the DDTs. They are not so common these days in our urban type of setting, but in the rural setting, you may have DDT, some poisonous plants, animal or insect bites. Okay, and then in our low and middle income countries like us, kerosene is also another very common type of poison in our home. I mean, it's very useful for lighting of fires, at home, but then children come into contact with it and then end up being poisoned. Okay. So what are the risk factors? As usual, the age matters, the child himself, the agent that is involved, and the environment also matters. Now, younger children, because they are smaller and closer to the ground, are at risk of getting, things that are closer to the ground. So if you store your bleach in cabinets on the, below the sink, for example, a young child who is exploring may easily open the cabinet and take the bleach out and drink. Okay, so because they are shorter and closer to the ground, that increases their risk. And then poisoning rates are increased around the age of 2. They are moving around, they can open doors, they can open drawers, they have access to things. And the liquid ones particularly attract them so much. And the more concentrated the agents, the more, the severer the morbidity and mortality that is involved. Okay. Now, the appearance of the substance also plays a very important role in attracting children to these poisonous substances. So if you have a colorful substance, I remember some time ago, the pregnant women used to be given the red, gold, green tablets, the iron, the folic acid, and then the multivites. So these looked like Smarties in those days, the M&Ms, the toffees that the children so like a lot. So a child seeing the mother's multivitamins, red, yellow, green, may think that they are Smarties, very colorful, very attractive, and they may just gulp them, and inadvertently swallow an overdose of iron and get themselves into trouble. So obviously, storage access is also another important aspect of poisoning. If you keep these household agents, medications within the reach of children, definitely they are going to get it and then get themselves into trouble. And then we also have this habit of dispensing kerosene and medications, especially into beverage bottles. We see kerosene in Fanta bottles, in Voltic bottles. Children have associated these Fanta bottles and Voltic bottles to drinking, and they take these kerosene or whatever substance, poisonous substance that has been stored in these things, and then just swallow them, thinking that they are taking a beverage. And again, we fool ourselves that tablets are in Ziploc bags, but then the children can figure out how the Ziploc bags work and open them and then gulp down all these tablets that we have stored away. And then improper storage of other, like the pesticide powders, they are white, and you store them close to food. People may mistake them for flour, milk, and the rest, and entire families have gotten themselves poisoned by this. So we should look at the way we store our things. So what are the interventions? Child-resistant packaging is one of the best documented ways of preventing unintentional poisoning in children. It's not 100%. It doesn't mean that the child may not be able to open the package eventually, but then it is a delay strategy in that, yes, they may struggle, but by the time they are able to open it, probably an adult may have come around to see them at it and would be able to take whatever substance it is that they are trying to open away from them. And again, taking storing things away from children is also a very important strategy. Storing it out of the reach of the child is very important, and avoid storage of kerosene. I stress kerosene in our beverage and then water bottles. How do we manage the child who has gotten himself poisoned? You remove the child from the source. You need to decontaminate the child if you can, and then assess what it is that the child has taken. What agent or agents has he taken? How much has he taken? When did he take it? These are very important questions that need to be answered because they affect the interventions that will be put in place for that child. And of course, definitely we need to stabilize that child. Usually you need to proceed to the hospital for that stabilization to take place. In decontaminating the child, remember that in kerosene, you never give palm oil. Do not, and I've written it in bold, do not give palm oil. Because what we do is to give palm oil, and then that makes the children nauseous, they vomit, and then end up aspirating the kerosene with the poison, with the palm oil and everything into their lungs. And that is what affects the outcome, giving us poor outcomes for such children. All around the world, there are poison control centers. So these centers are there to provide first aid information to help parents give the necessary care, the first aid care, and then maybe onward journey to the medical center. In Accra, the poison center has this number. I must admit that I called, it wasn't going through, but it is located at the Ridge Hospital. Now, quickly going through choking, suffocation, and strangulation. These are, they occur on a daily basis in our homes. I keep talking about how children are curious and always exploring their environment. So we need to always look out for them. And then they have very small airways, and that can be easily blocked. And that is what makes it very easy for them to choke and then suffocate on whatever it is that they have gotten themselves choked with. So in and around our home, some of the common items that present as a choking risk for our infants are food. So certain foods can be very dangerous for our children because they are easily inhaled and then they block the breathing tubes. So the nuts, the raw and hard vegetables, we have apple, popcorn, and lollies, the grapes, and all of that. Children may not have the full set of teeth to eat these things. So it's better for you to sort of chop them into smaller sizes. For the apples and the hard vegetables, you can stew them, you can mash them, you can puree them and make it easier for the child to eat. And then how do you prevent choking on the food? You ensure that the child is sitting quietly whilst they are eating or drinking. It's difficult, but then we need to start teaching them the manners very early, that you don't move around whilst eating and drinking. And then you never force your child to eat. So because this may cause them to choke. You don't give whole nuts to children under 5. And I've talked about mashing, pureeing, hard vegetables and fruits for children. For grapes, you can cut them into smaller pieces. You mince meat for them instead of giving them the whole meat to chew on. Serve it without the bones. And then never prop your child up and then put the bottle in their mouth and expect that they will just suck, and then that's it. That may present as a choking hazard for the child. And then the small objects around the home. So the safety pins, the small coins, the buttons, the seats, the marbles, all these present as choking hazards for children. Prevent your children from getting into contact with these, and then get them the appropriate toys to play with. So toys that do not have small parts, because if these small parts, especially if they can be removed, are a choking hazard for them. And then the batteries in these toys, you should always make sure that they are always screwed into place so that the children are not able to remove them and put them into their mouth. I'll mention curtains here. We may have curtain cords and all of that. Those present as strangling hazards for the children. So instead of using the cords, you may use the rods rather. Or if you are using curtain cords, you need to fasten them away from the children so that they do not get access into them. Access to them. They may be playing their hide and seek behind the curtains before you realize someone has used the cord to, wrap around the neck, and that acts as a choking hazard. So that's a picture of a baby in a choking situation with the curtain cord. Plastics, we use them every day in our homes. You make sure that after you have used them, you tie them so that the children do not get access to them and pull them over their heads, because once they pull them over their heads, they will suffocate. And then store them away from the reach of children. Beware of clothing such as the hoodies. They have drawstrings in them, which may be caught up in play equipment. And then that may end up as a strangulation hazard for the child. Before you put your baby down, make sure that the babe is removed. There's no necklace, no jewelry that can be caught anywhere on the bed to act as a choking hazard to strangulate the child. So for choking, we must all also learn how to give the first aid, the CPR. Usually you have to call for help. For the younger children, we give the back slaps or the blowing of the back to thrust out whatever it is that the child has taken. So that's a picture of someone performing the back slaps to help bring out the item that has caused the choking in the child. So I have come to the end of my presentation. These are a few take-home messages I want us to take along with us. We should remember that children are not miniature adults. They are growing, they are developing, they are curious, they desire to explore their environment, and this makes them prone to injuries from accidents. So we need to keep a constant eye on these children and remember that even as they are growing, even though their physical activities are increasing day by day, month by month, their cognitive abilities and intellectual development do not match these physical activities, and so they are not able to respond appropriately to danger. And so this makes us adults, we have to be sure that we are always watching out for them and making sure that they do not fall into any kind of injuries, and we need to prevent them from the injuries and deaths from home accidents. So this is the end of my message. These are my references. Thank you very much for your attention.
Thank you very much, Dr. Wood, for such an eye-opener and a very interesting presentation. We will let Dr. Samira take over immediately. Kindly put your questions in the chat box, and when Dr. Samira is done, you can then ask questions to both of them. Thank you. Dr. Samira, your audience. So as a reminder, Dr. Samira is going to talk about Titbits in Pediatrics. And so with rapt attention, let us see what she has in store for us.
So good evening, everyone. Thank you very much, Dr. Mabel, for the opportunity. Dr. Wood has started off very well, has given us a good introduction. I'm going to be talking about Titbits in Pediatrics. So I picked a number of topics that I know is of great concern to a lot of parents. And then we are going to be touching on quite a number of topics. Sorry. Please, my slide's moving. I think I'm having a bit of a problem with that.
Yes, they are moving.
No, okay. So there's an outline of the presentation. So we are going to talk a little about problems in the newborn and infant period, and then immunization, common skin conditions, and then we'll talk about some misconceptions in child health. So the newborn period. So the newborn period is a time where there's, especially for new mothers, great concern and confusion, and then there's a lot of information out there, and then you're not sure exactly what you should be doing. So breastfeeding, as we know, Ghana Health Service recommends a 6 months exclusive breastfeeding, and then complementary feeding starts from 6 months. We're often faced with the question of how much my child is getting, whether my baby is feeding enough. The picture on the right here shows us the capacity of the baby stomach. So for a newborn baby on the first day of life, the capacity of the stomach is just about 5 mils to 7 mils. That is less than 2 teaspoons. So a baby is actually, when you feed just about 1 to 2 teaspoons of milk, is actually enough to fill this baby's stomach. What it also means is that the baby needs to feed more frequently because it will empty quickly. And so we usually recommend that mothers follow the feeding cues of a baby. Every baby has their own feeding cue. It could be crying or even rooting for the breast when they are hungry. But in all of that, we also recommend that at least every 3 hours, the baby should be fed. And then from the picture we are seeing, from the first day to the third day, the capacity increases, and then until about a month, and then it continues to increase as the child grows up. Okay. Another issue is infantile colics. So cause of infantile colics is greatly unknown. Okay, we know that babies tend to cry a lot, start from around six weeks to about 3 to 4 months. And they usually cry excessively in the evenings. And it's usually predictable, happens about 3 hours in a day, about 3 days in a week, and greater than 3 weeks continuously. And the cause is actually unknown. There are some associations. For example, we know that it can be associated with certain food allergies. So if mother is feeding, is eating something that baby is probably allergic to, they could cause some of these problems. It could also be overfeeding, and then even stress and anxiety. Okay. And the treatment is usually just soothing strategies. You should, sometimes we'll recommend some medications, but it's not really known to visually help. And then the main way to manage it is to give, to soothe the baby. And the mothers can also adjust their diet when we suspect that it's probably the food allergies. Another issue could be reflux. So babies with reflux could be given some medications, and then it would help with, to calm them down. Apart from that, it usually resolves by the time they are 3 to 4 months. So this is a baby stool chart. So normal stools for babies we usually have varying colors. Doesn't always mean that baby is sick. So on my picture, I hope you can see my arrow. On the right side, that's a mustard yellow stool. This is the normal stool of an infant that is breastfeeding or even being formula fed will have this normal mustard yellow color. You could have this bright yellow color as a result of certain medications, but it is still normal. The light green frothy stool can be because the child is getting more fore milk than hind milk. So fore milk is the milk that comes when mother starts to breastfeed. It usually contains a lot of water and less fat. Okay, so that's why I recommend that the baby should breastfeed on the breast, at least empty the breast so that the child can get both fore milk and hind milk. So you will get this light green frothy stool if child is getting more fore milk than hind milk. Okay, then we can have this greenish tan, which actually could be normal, or babies who are on formula could also have this color stool. The dark green stool could also be from iron. So if a child is on iron supplementation or on some iron-rich formula, that could cause the dark green stool. White stool is of great concern. So if you see a stool which is white or chalky, as we describe it, looks like the chalk that we usually use to write on blackboards. that is of great concern, and it is usually a sign of a liver problem, and this should be quickly brought to the hospital. Next to the white is the grayish stool, which can be normal in children who are feeding on solids. But for a baby that's being breastfed, gray colored stool is of concern and should be reported to the hospital. The black stool is usually normal in the first 48 hours of life. That's what we call meconium. After about 2 days, if you are still seeing black stool, then it's of great concern and should be reported to the hospital. Red stool here. So if you have just streaks of blood or reddish blood in the stool, it could be a result of constipation. However, if you're seeing a lot of red blood mixed with the stools, then it's a sign that child may be bleeding and should be reported to the hospital. So, okay. The next thing I'll be talking about is sleep. So infants require about 12 to 16 hours of sleep in 24 hours. So this is not just limited to the night. This includes the daytime naps that they have. So a child could be having about 2 or 3 naps during the day, about 2 hourly naps during the day, and then gets to sleep some at night. That is perfectly normal for an infant. So children 1 to 2 years, they require about 11 to 14 hours of sleep, also within the 24-hour period. And then 3 to 5 years, about 10 to 13 hours in the 24-hour period. Children 6 to 12 years require about 9 to 12 hours of sleep. And then the teenage period is usually about 8 to 10 hours of sleep a day is usually enough. This is from the American Academy of Pediatrics. So other things of note in the newborn period is that it's important to have a newborn baby reviewed by a pediatrician within the first week of life. This is important to assess for any congenital abnormalities that may be present, or to look for any alarming signs that may be present at birth. Okay, and it's the first week assessment is actually very important. And then you have to plan for follow-up visits, usually at 6 weeks, then at 3 months, then 6 months, 9 months, and then the next one will be at 1 year. And then subsequently, we recommend 6 monthly visits. These visits are to assess the child's growth so that we can pick up early signs of any developmental problems or any other problems that may be present. It's important so that such signs may be picked up early and then so that we can institute appropriate interventions early to prevent future problems. Immunization, I'll talk about it in the coming slides. And then supporting mental health. So this is something that is often overlooked, but the newborn period is very challenging, especially for new parents. It's life-changing. There's a time that mother is learning how to cope. Both parents are learning how to cope with a newborn, and then the life changes that come with it. It is very stressful. Nobody knows it all. And then that's a time that we actually need a lot of support from family members. It's very important, family members and friends, to show some support and offer some words of encouragement. It goes a long way to help the mental status of both parents, not just the mother. So immunization. So this is currently the recommended immunization schedule in Ghana. Every country has its own schedule. So this is currently our schedule. And we know that in recent years, there have been a lot of issues with vaccination. Recently, we had shortages of a lot of these vaccines. And thankfully, last week, a lot of vaccines came into the country. But before that, during the pandemic, we know that a lot of children also missed vaccinations because a lot of people were scared to go to hospitals for a very long time. And so now we are seeing conditions, especially measles. Measles has been reported in certain regions in Ghana. And this is quite worrying because for several years, a lot of us have not actually seen cases of measles. So measles is just one of our vaccine preventable conditions. So we are just hoping that the others don't start to come up. But in case anybody has missed any of these vaccines, there is still room for catch-up. This table I've projected is currently the recommended schedule for catch-up. So BCG recommend that until a child is a year old, it can be given. So for anybody who has missed any of these vaccines, you should go to your nearest child welfare clinic. So as the table shows, so for the 6 weeks vaccines, there's usually room for up to 5 years. That's the oral polio vaccine, the penta vaccine, the pneumococcal vaccine. You can still take it. It's not too late. So if anybody on the call has missed any of these vaccines, there's still room for you to get these vaccinations at your nearest child welfare clinic. Now we are going to talk about some common skin conditions in children. We'll be talking about atopic dermatitis or eczema, diaper rash, seborrheic dermatitis, erythema toxicum, impetigo, tinea, and then Mongolian spots. So this is atopic dermatitis. So atopic dermatitis is a chronic condition. Chronic means that it's there for a long time and then it's relapsing. It means that it goes and then it comes. It gets better and then it comes back. So these children usually have these dry, flaky patches, usually on the face, and it's common in the flexor surfaces. What I mean by that is in the elbows and then in the knees. Okay, this is thought to so there are a lot of it could be as a result of allergies. It's also immune related. Okay, and then the mainstay of managing this is usually emollients. And if you have any of these skin conditions, it's recommended that you see a dermatologist or a pediatrician. There are a lot of therapies available for them. And then, like I said, because it's chronic, it needs regular follow-up, long-term follow-up for you to be able to manage this skin conditions. They're usually very itchy. It usually interrupts the child's sleep. And then sometimes it can actually limit their activity because with a little sweat, it becomes very itchy and it's very uncomfortable. Next is seborrheic dermatitis, what we also call cradle cap. This is common in the newborn period. So that's for infants. You usually see this yellow crusty lesions in their scalp, just under the hair. It's just limited to the area around the hair, okay? This is actually due to oil buildup in the scalp. And then management is quite simple. It just involves wetting the hair, applying some oil to it, and then you can gently flick it off with a brush or a soft comb from the hair, and it usually just goes away. Doesn't require any antibiotic therapy. This is erythema toxicum. So erythema toxicum is usually a rash we see in the first few days of life. It usually clears by the time the baby is 2 weeks old. These rashes also do, even though they may look worrying, they actually do not require any therapy. They are rashes that go on their own. They do not require any antibiotic therapy or do not require any special treatment. They usually go away on their own. So that's erythema toxicum. So usually clear by 2 weeks. Then Mongolian spots or Mongolian blue spots. These spots are quite common, which we usually call birthmarks. You usually find this in the back, usually common at the back of the babies and then the lower back, okay? These ones are also not problematic and they usually do not cause much problems and they usually clear by the time the child is between 1 to 2 years old. And it is not of great concern. The next is diaper rash. So diaper rash is usually, it's thought to be caused by, it comes when children usually stay in their diapers for long. So there's a prolonged contact of the skin with the wet diaper. Okay, so you usually see that the rash will be limited to the area that is covered by the diaper. Okay. It's usually limited to the areas covered by the diaper. The flexures, the folds in the skin are usually spared if it's just diaper rash. But we should note that you can also have bacterial or fungal infections associated with this. And when there is bacterial or fungal when there's superimposed bacterial or fungal infection, that will require topical antifungal or topical antimicrobials. But the management for diaper rash is usually with what we call a barrier cream. Most recommended is zinc oxide. So zinc oxide should be applied on the nappy area at every diaper change. And you shouldn't let child also stay in the same diaper for a very long time. Should change diapers frequently and then apply the barrier cream. In case of superimposed bacterial or fungal infections, then the topical antibiotic or antifungal cream would be added. So the next on the list is impetigo, which I think locally is commonly called it's commonly called tomatoes. Yes, that's what we call it locally. So you would see on this child's face, it can actually occur in any part of the body. In this child's face, you can see different lesions. They are all at different stages of development. Some of them are quite small. The ones around her mouth have crusted over with some yellowish crust on them. And that is how impetigo usually occurs. This is usually caused by a bacterial infection of the skin. And this will usually require antibiotics, okay? In very small children, they can cause very severe infections and then they may even require admissions. However, in older children, sometimes the use of just oral antibiotics with topical antibiotics and the use of antiseptics in their baths would usually help to resolve this. But in very little children, when they have this, it's of great concern, and then the doctor should be seen for its management. Tinea infections. So these are quite common. Tinea infections. So tinea on the head is called tinea capitis, and then on the skin is called corporis. You can also have it in your in between the finger. It's in the fingers. We call it tinea manum. And then in the feet is tinea pedis. Okay, these are all fungal skin infections. These ones are treated usually with oral antifungal. You cannot use just a cream, just a topical antifungal cream to treat this. And the treatment is usually for a prolonged period of time. And that's where the problem is, because a lot of people are not able to complete the treatment. Treatment is usually between 4 to 6 weeks with oral antifungals, and you should see a doctor for a correct prescription, okay? And in addition to these antifungals that we usually give, we usually give some other antifungal shampoos which can be applied on the skin, and then there is also antifungal topical creams. But topical cream alone is not enough to completely treat this. And this is also very, it's easily transmissible among children, okay? So usually you would have to look at once one child has it in the home, you look at the other children. You should avoid sharing of things like combs, sharing beddings and all that, because these dermatophytes can easily spread from child to child. And so it takes a long time for it to be treated. Okay, so there's tinea capitis and then there's tinea corporis, as we are seeing in these children. So before we end, we'd like to talk about some myths and misconceptions in child health. I know some of these statements here are a bit controversial. People have some different opinions, but let's go through a few of these myths. So the first is all high-grade fevers require antibiotics. Yes. So not every fever is caused by a bacterial infection that requires antibiotics. See, the commonest cause of fever in children is usually viral infections. And most of these viral infections are self-limiting and actually do not require much treatment. It's usually supportive care that is required. Supportive care with antipyretics like paracetamol or ibuprofen syrup, and then ensuring adequate hydration and feeding is usually enough to manage these fevers. Okay, so not every fever requires antibiotics. A lot of these coughs and colds are usually caused by viruses, and they come with these fevers, and which would usually go away without antibiotic therapy. And second is air conditioning or exposure to cold causes pneumonia. So air conditioning per se does not cause pneumonia, but we also know that when air conditioners are not frequently serviced, they may harbor some bacteria that may cause pneumonia. So it's not exactly the air conditioning that is causing the pneumonia, but it's actually the lack of servicing. And there's a lot of research in this area with conflicting views, but we know that it does not cause pneumonia. Okay. So teething causes fever and diarrhea. So teething actually causes a lot of discomfort, okay? And it's common to have some low-grade fever with teething, but teething should not cause you to have a severe fever, a very high-grade fever and diarrhea and a runny nose. So in case a child who is even teething has any of these symptoms, it means that you should seek medical attention. You shouldn't just assume that it is the teething that causes it. Teething will only cause a low-grade fever, but will not usually cause diarrhea or a runny nose. Okay. And then formula-fed babies always have to drink water. That's also a misconception. Once your formula is mixed with water, which is actually enough. They just need to, in hot weather, we usually need to feed more frequently. They do not need to add any extra water just because they are formula. Okay. The next is a baby has to poop every day. So it's normal, especially for breastfed babies, to go for as long as even 5 days without passing stools. Okay, as long as there is no abdominal distension, that's the baby's tummy is not tense, child is not very fussy and is not vomiting, and he's actually very comfortable in passing gas. It's actually normal. It's very normal for a baby to go through long periods for such days, about 5 days without passing any stools. That is very normal. Okay. And the next is a pregnant mother should not breastfeed. This is also a misconception. There's nothing that prevents a pregnant mother from breastfeeding. It is not a contraindication at all. And then the last, before I end, is a baby should never be left to cry. All crying in babies is ominous. So I know there are some parents who would insist that they will carry their babies whenever they cry, but once a baby is well, once a baby is well, it has been fed, does not require a diaper change, is not ill, doesn't have any other signs, any signs of any serious illness. Babies do cry sometimes, not just because they are sick. It's not every cry in a baby that means that there's something very serious going on. It's some people recommend that it's also a coping mechanism. As babies cry, sometimes you're able to soothe them. So that's not to say that we shouldn't carry our babies when they are crying, but really when a baby is well fed, is not in any form of discomfort, sometimes they can cry and then they can soothe themselves. It's a self-coping mechanism, and then they're able to calm themselves down and then they go to sleep. Okay, so this is my last point. This is my very, very short presentation on tidbits. We can continue with our discussion. Thank you very much for your time.
Thank you. Thank you so much. I've really enjoyed today's presentations. Thank you, Dr. Wood, and thank you, Dr. Samira, for taking us through these things. I'm sure all of you on the call have really enjoyed and you have some questions. Let me start by saying that if you do not have a pediatrician, it's very recommendable for your family or your children to have a pediatrician. And if you don't have one, we are very glad to take you on a Mission Pediatrics. We have a pediatrician available most of the time. From Monday to Saturday, there's a pediatrician available. So let us now answer some questions. So the first one, when a child falls and there's a swelling on the head, I think this will go to Dr. Wood. What do you do in terms of first aid? And then maybe let me do it two at a time, because the first two is also for Dr. Wood. And please, what do you give as first aid in case of kerosene injection?
Okay.
So for those two now.
All right. Okay. So when a child falls and then there's a bump on the head, I mean, the first thing to do is to, yes, clean the area. So clean it with water. You may clean it with some antiseptic solution, and then you can apply a cold compress, to the area that is affected. That's basically just about how much you need for a swelling. But of course, if there are bruises and there are cuts, yes, then you may need like further medical care. So if there's a huge cut, for example, that may need suturing or something, then of course you need to advance for further medical care. Now for kerosene poisoning, what to give? Yes, we have said that we shouldn't give palm oil, but really, there isn't anything that you can give. Inducing vomiting is a contraindication. You cannot give what's it called? You cannot give something for the child to vomit the kerosene out. And also, even in the medical setting, we may not even want to put in something to wash out what the child has ingested. Usually what happens is that now the taste is off. And so that actually puts them off. So most children will actually not drink a lot of the kerosene. Once they put it to their mouth and taste that it is not water, it is not pleasant. It's just a small amount that they will take anyway. And that usually does not cause much harm. So even in the hospital setting, they are just there for observation. We just keep them for a couple of hours, about 6 hours, just to observe, monitor their oxygen content in the blood, just to make sure that the oxygen values in the blood are not going down. So really, there isn't anything that you can give as first aid. It's more of they've taken it, we need to observe them and see what happens. If they need any intervention in the hospital setting, we will give it.
Okay. Thank you. Thank you very much. So please do not give palm oil, and do not try and get them to vomit, because that will cause aspiration. Means that as they are vomiting, the vomit can go into the chest, and then they can get more complications like a pneumonia, and they can't breathe. And sometimes we even have to put them on a ventilator. So don't give palm oil. The next two questions are about gripe water. So Dr. Samira, is gripe water helpful for treating colic? And is it recommended for colic in babies?
Okay, thank you very much for the question. So the issue of gripe water, really, I haven't actually seen any evidence supporting its use. But a lot of mothers still insist, all mothers insist that it actually works, but I haven't actually seen anything confirming its effectiveness. It's mainly the soothing mechanisms, and we know that it usually goes away with age. I don't know if you have found anything like that, but I haven't.
Okay. Dr. Wood, you can always chip in if there's anything you want to say. For me, I say gripe water is to treat the mother, not for the children. It helps the children to say, the mom to say we are giving something. We've all used it before though, but there's no evidence. Okay.
Yeah, I also haven't come across any evidence. And in fact, I tell my mothers that, well, it doesn't work. But well, if you feel you want to use it, you can try it and see. But really, there's no supporting evidence, and I haven't really seen it work before. Yeah.
Okay. Thank you very much. There's a question about when babies are teething and they have dark green stool. What does that mean?
Okay, so I think it was actually in the poop charts that I posted earlier.
Okay.
Yeah, the dark green stool, it's actually common in teething children. I'm trying to go back to that page. Yes.
Okay.
So if you look at the top, the greenish tan, it mentioned that it's actually associated with teething.
Yeah. Wow, that's interesting. Okay. Yeah. So it's there. Question answered. So it's nothing to be afraid of, right?
Yeah.
No, it doesn't need antibiotics, please.
No,
okay.
it doesn't.
All right. Then what is the difference between impetigo and pemphigus? Hey, so big questions though. Anyone want to, any of our speakers to answer? Yeah.
Impetigo, like I mentioned, is usually an infection, okay, usually staph bacteria. But pemphigus tends to be more of an autoimmune condition of the skin itself. So like that, it's one of the blistering conditions of the skin. So it tends to be more of a chronic condition rather than like with impetigo, where it's a very infectious condition, you treat it and then it goes away. But pemphigus is more of an autoimmune blistering condition of the skin itself.
Thank you. Thank you very much. Somebody wants to know how they're going to get CPD points. So if you're on the Parents Roundtable page, there's a link to register if you need MDC CPD points for this one. It will answer other questions about what it will cost and how many points you get. So please get the link. Godfred, if you are still on the call, can you send the registration link for CPD points onto the chat box? Thank you.
Okay.
Copy of the recording. So the recording is on our YouTube page and also on our Facebook page. We will post the link to those pages also, so you can go back and listen to this. The slides will be there, everything will be there. You can listen as many times as possible. Can you give charcoal or for food poisoning?
Charcoal.
Yes.
Well, I'm
activated
not
charcoal.
Maybe activated charcoal, but even that, I'm not sure we don't give activated charcoal for food poisoning. I know we give activated charcoal for like some medications that have been taken within a certain number of hours to sort of, absorb or to take it away from the stomach. That is, if it's even still in the stomach at that time. Yeah. But for food poisoning, usually is caused by maybe viruses, bacteria, and all that. Some of them are self-limiting. For some, you may need to give antibiotics. So we don't use activated charcoal for food poisoning. No.
Okay. Thank you very much. If a child is 8 months with no teeth and is still struggling to stand without wobbling, is it a concern? Can I answer that, please?
Please do.
No, it's not a concern at all. If your child's teeth have not come at 8 months, don't worry. I have a niece whose teeth came out at 22 months. Can you imagine? Her first incisors came at 22 months. But no, 8 months, you shouldn't worry. And if struggling to stand without wobbling, so it depends. If you are still supporting them and they cannot bear weight at all at 8 months, then there may be a concern. So bearing weight means that you have your hands under their armpits and you put them on your lap. Can they stand? Can they bear a bit of their weight on? They should be able to do that at 8 months. But if you are expecting them to stand on their own, as in they are holding a table or holding the sofa, 8 months is a little early. So if they are not doing that, that is not a concern. Please, as speakers, do you have anything else to add?
No, Marilyn, you've answered it all.
All right, thank you. Please, how many hours long should a child between 1 to 4 years be fed? I'm not sure about this question. Please, how many hours long should, I think the person is asking about interval feed, of feeding for a child who is between 1 and 4 years.
Okay. So I think it's recommended that at that age they should be feeding up at least about 5 times a day. That includes snacks. So
Yeah.
we have about 5. So that would be about maybe about 5 hours. I'm not sure about that, but yeah. But it's recommended that it's about 5 times a day, including snacks. So about 2 snacks in there.
Okay.
Yeah. So
Okay.
3 main meals and then 2 snacks.
Yeah. Okay. So 3 main meals and 2 snacks. So breakfast and then lunch, and in between breakfast they should have a snack. Then between lunch and dinner too, they can have a snack. And if you like a last snack before they go and sleep, it's all allowed. Okay. Can copies of presentations. So as I said, you can get the presentations on the YouTube page and the Facebook page, please. Dr. Wood, can we give activated charcoal to kerosene injection kits, especially within few minutes or up to 4 hours of the occurrence? I think this may be a resident or a doctor.
So as I said, well, unless there's something else that I don't know, but usually you don't give them anything. In kerosene injection, you have to wait and see what happens. And as I said, usually they wouldn't have taken a lot.
Yeah.
Would have taken a very little amount. It is us giving them things to drink that causes them to vomit and then now aspirate. And then when the kerosene mixed with whatever it is that you've given them gets into the lungs, that's when it starts causing the inflammation and then causes them to lose oxygen, and they may need oxygen and eventually may even need intensive care. So usually it's a watch and wait affair. You don't really have to give them anything.
Okay. All right. Thank you very much. Another question that I suspect is from a doctor says that, what do you do when mothers are complaining that their child is stretching too much? What do you do when a mother complains that the child is stretching too often? I think that's to go to Dr. Samira.
Okay, so the issue of stretching is actually quite normal. It's normal. I know sometimes it's usually associated with the irritability that comes with the colics, but stretching is actually not a problem that you should worry about.
Okay. All right. Thank you very much. So please reassure the mother, especially if it's a new mom, that stretching is normal in babies. It's part of development. I tell them that the baby has been coiled up in this womb like this for 9 months. They have come out. They have to stretch their bodies and feel free. So it's all parts of development. Okay. And I know that babies who have colic too can stretch quite a bit when they are uncomfortable. So they can stretch quite a bit. But we've learned that colics is nothing to worry about. So there you go. All right. What can you apply on babies when they have heat rashes? I must say, Dr. Samira, I really loved your rashes presentation. It's very interesting. What can you put on babies when they have heat rashes? And why don't we use, the question says, and why don't we use powder on babies anymore?
So heat rashes, it's usually because there's heat and then you are clogged, the sweat pores are all clogged up. That's why you end up with heat rashes. So the important thing is to keep the skin clean and then dry. Okay. Powder tends to clog those pores up. So even though you're trying to keep the child's skin dry, the powder is ending, you're going to end up clogging up those pores, and then you end up making it worse. So powder and oils are usually not recommended. So as much as possible, you keep it clean and then dry as much as possible.
Thank you. Thank you very much. So
You
I
can
know
also-
when we were, sorry.
So I'll say you can also like use light clothes, like just to make the child a bit more comfortable, light clothing, yeah, just to give some airiness
Yeah.
for the child.
Okay. Okay. If it's really bad and they are itchy, sometimes we can even use calamine lotion. Calamine lotion we can use for everything to soothe the skin. So we use calamine lotion. I know I have used milk of magnesia before. It really suits the skin also. But the main thing is to get the heat away from the skin. Okay. And why don't we use powder anymore? I mean, when we were younger, they used to powder us after bathing in the evening, powder your face, especially with the girl children and everything. But now we are not using powder anymore. I mean, there's been an issue of talcum in a lot of powders that we know now causes issues later on. And so I don't know if they have powders without talcum anymore. I mean,
Dr. Mabel, so with that, there are some powders that are without talcum. So we have cornstarch based powders that are available now. I've seen that, but haven't really looked into it, but I've seen it.
So I suppose we can use that one if we need to.
Possibly.
Yeah. Okay. All right. So if you want to use powder, you can just make sure there's no talcum inside. All right. So shout out to Rex Mate, my cousin who is listening in. He's asking about kerosene poison again. So Rex, we said that for kerosene poisoning, there's no first aid at home. The best thing is to rush the child to the emergency so that we can observe and make sure that no other complications occur. So at home, no, you can't do anything. All you need to do is get the child to hospital. The most important is that don't attempt vomiting. So don't give mixture of milk and palm oil and all sorts of things to get the person to vomit. Right. Please, what then do you recommend for colic? Do we just observe? Another colic question.
Yes. So like we said, yeah, soothing mechanisms. So tummy time, burping after every feed. Yeah, and then what? Avoiding overfeeding, keeping them upright when you feed. Those are usually the soothing mechanisms, but nothing really medically, nothing really.
Thank you very much. There's a good parents book for colics. It's called The Happiest Baby on the Block. So for those of you who are really, having issues with colics, I suggest you look for this book. It talks a lot about the soothing mechanisms and things you can do, the jiggling, the wrapping, the rocking, all sorts of things that you can do for colics. So look for it. It's called Happiest Baby on the Block. Is by something Harper. I'll find it and post it on the Parents Roundtable. All right. Then the last question, please, does the use of fan cause pneumonia?
I think I mentioned, okay, I only mentioned the air conditioning. So the answer is fans do not cause pneumonia. Pneumonia is caused by bacteria. Okay, so you can have bacteria, yes. Can have bacterial pneumonia, yes, but not.
Thank you.
Thank you.
How do parents join? You mean the Parents Roundtable? Okay, Godfrey, can you please post the link to join Parents Roundtable and WhatsApp group so that if anybody on the call is not on our WhatsApp group, kindly join. We usually answer questions, post a presentation, and then we also give announcements about the next presentation. Last question, please. Anything on speech delays and when it's ideal to seek speech therapy? Okay, let me answer that question. So So that's a very wide question. Okay, so speech delay. If at any time you are concerned about your child's speech, is the best time to seek for therapy or for intervention. Do not wait and see. Don't say, oh, this child is too young. This child is a boy. This child is the firstborn. This child doesn't have siblings, or I'm the only person with this child, so it's okay for the child not to be speaking. So you should look at, yes, Happiest Baby on the Block is by Harvey Karp. So look for that. Okay. So for speech, we usually say that by 1 year, they should be saying at least 1 or 2 words. By 18 months, they should have about 18 words. By 2 years, they are putting 2 words together in a sentence. By 3 years, they are putting 3 words together in a sentence. And by 4 years, they can tell a story, they can decoconsa, they can talk like you and I. So if at any point of these times, your child is behind 1 to 2 words at 1 year, 18 words at 18 months, putting 2 words together at 2 years. If your child is behind at any of these milestones, please seek help. Come to see a speech therapist, see your pediatrician, and you will get early intervention and you get help. Thank you very much. We have the link for joining the Parents Roundtable in the chat box. So if you are not on the group, kindly join us. We also have the registration link for the health professionals who need CPD points for this meeting. And as usual, we are very grateful and appreciate your presence at these meetings. You make it worthwhile. Next month, we'll be talking about anxiety and mental health challenges in children and adolescents. It will be taken by our 2 child psychologists at Mission Pediatrics, Dr. Pierre and Dr. Ethel Obing Trevor. So make a date with us next month, 3rd Saturday of the month. And I'm sure we are going to have a wonderful time. Please, if you do not have a pediatrician, come and see these wonderful pediatricians who have talked to us. They will be at Mission Pediatrics on Saturdays if you are busy during the week. And I am there during the week. If you are busy during the week, please come and see Dr. Wood or Dr. Samira. Thank you and see you next month. The link for the CPD points is there. Godfrey, did you put it there? Yes, it's the one that says register your details in the link below. That is the link for the CPD points. So Nelly, kindly look in the chat box. You will see that link also. And if you are on the page, we will post that link there also. Thank you very much, Dr. Samira. Thank you very much, Dr. Wood. Dr. Wood, we didn't see your face, so Okay, thank you very much, Dr. Wood. It's been a wonderful evening. See you guys next month. Bye-bye.
Bye. Thank you.
Bye.